Hi, welcome all of you. I am Dr. Aniket Mohit. I am a DM hematologist, oncologist, and a bone marrow transplant physician at Arogya Multispecialty Clinic and Kolhapur Cancer Center. I'm currently a part of Vancouver General Hospital, which is in Canada. So, as we know, it depends upon the type of chemotherapy, the diagnosis, as well as the area which we are targeting in cases of radiation. Before the advent of some new chemotherapies, the risk of infertility, that is, not being a father of your next kid, was a problem with majority of the chemotherapy regimens which were available for treatment of cancers. It may be hematological malignancies or maybe something like testicular cancers, prostate cancers, or colon cancers, or other solid organ malignancies, which may require a combination of chemo and radiotherapy. So it depends upon the diagnosis as well as the type of chemotherapy and the medications which we use. For example, in the past, for treatment of diseases like Hodgkin's lymphoma, the risk of male infertility was high because of the chemotherapeutic drugs which were used. But with the current advent of new drugs like the ABVD regimens, the risk of infertility or oligospermia or decrease in the sperm count is kind of short lasting or temporary, and it usually recovers in few months to maybe a year. Especially in leukemias where the intensive chemotherapy is required for treatment of malignancies, the risk of infertility is high because the amount or the dosage of the drugs which is required to treat or control those diseases is pretty intensive as compared to those with treatment of lymphomas. So, in such cases, in males, we can always do an ejaculation and collection of the mature sperms before starting the chemotherapy regimen and cryopreserve those sperm cells for use in later for IVF or intracellular sperm injection, which is called as ICSI. These are all the techniques by which this cryopreserved sperm can be used with in vitro fertilization or I mean intrauterine insemination, which can be done by the gynecologist or the infertility specialist. But sometimes, in cases where there's a risk of disease which is aggressive and we do not have the time to discuss or have life threatening complications where the patient is not in a scenario to either consent or to decide for himself whether he wants to go for some cryopreservation or any of the other techniques which need to be done. In such cases, we the most important thing is to save the life of the patient and to proceed with chemotherapy. In some cases, we can go ahead with the chemotherapy and try collecting the sperm or to do an intratesticular biopsy when the disease burden is less. Sometimes the testicles or the scrotum can also be involved in diseases like lymphomas and like ALLs. So, or they may require testicular irradiation as a part of the therapy in later on in as a part of treatment. So, in such cases, we usually try not to collect the specimen while active disease, but rather collect either the semen or do a testicular biopsy when after the induction chemotherapy is completed and the disease is kind of controlled, so that the risk of transmission of malignant cells or the risk of getting spreading the disease from the sperm or from the sample is reduced. Procedures like testicular biopsy would be deferred because to begin with, uh, during the diagnosis, the patient will have low platelets, may have bleeding diastasis, may have coagulopathies, which can defer the situations of doing a interventional procedure like even a small procedure of testicular biopsy and putting it in a risk of spreading the disease to the testicles when it may not be present at baseline, which increases the risk of patient of testicular spread and can make them high risk. The importance of discussing this topic is that number of patients either at the time of diagnosis or are unaware about the risk of infertility, and later on in the future after completion of the treatment their psychological aspect can be affected in males as well as in females from the infertility aspect or not having a child in future because being diagnosed with cancer with the risk of spreading the disease to your future generation or spreading to your spouse, as well as having not having your next kin or your child can have a psychological effect in both males as well as in females. There is no need to panic about not able to have a kin or not able to have your next generation from yourself. Even if you are not able to do a sperm cryopreservation at the start of therapy because of life-threatening complications like brain bleed, bleeding diastasis, having melena, or having tumor syndrome or DIC-like complications, which can happen when patients are diagnosed with hematological malignancies like leukemia and lymphoma, we can still do it after your first cycle of chemotherapy or your induction chemotherapy, which we typically call. The chances of conceiving from to your partner or conceiving if your partner is not yet there or existing and you're unmarried while you're receiving chemotherapy, you can still do a sperm cryopreservation, and or even though your sperm count would be low, in ICSI, which is an IVF technique, can still be tried, or in vitro or IVF techniques with the near advanced technology can still be tried to have your next future generation. A testicular biopsy, ultrasound guided, with a biopsy of the spermatogonial stem cells can be tried, and the sperm cells can be produced from those spermatogonial stem cells, though the rate of conception of your partner or your spouse is lesser compared to doing a cryopreservation at baseline before you get any chemotherapy, because the radiation or chemotherapy is chemotoxic. It's toxic to your sperm cells, to the mature, as well as to the spermatogonial stem cells or the sperm supporting or nurturing cells in your testicles, because this is one of the cells in the body which are rapidly growing and are affected by chemo as well as radiation. In bone marrow transplant patients, even though they may not have received or maybe still fertile before undergoing transplant, they in cases, especially in cases of lymphomas where the chemotherapies are not that intensive or they do not affect the sperm cells to the extent they can affect in leukemia patients, you can still do a cryopreservation before you undergo intensive therapy like transplant, especially in benign diseases as for transplant patients for aplastic anemias or sickle cell anemias or thalassemias, where you can undergo your sperm cryopreservation and then do your undergo the intensive therapy. With transplant, you have an option of doing an antenatal genetic testing if you are worried about transmitting diseases like thalassemia or sickle cell to for the generation, whether the child is affected or not, with the current available genetic testings, which can tell you before whether you the embryo or the fetus is affected, yes or no. So coming to the fertility preservation in females, it is totally different or completely separate compared to males. I mean, females are born with the oocytes or the oogonia, which we call, which mature and then form follicles right at birth, and they do not have a capacity to keep reproducing or do not have stem cells in the ovary, which we call as. So because of this, they are limited, and chemotherapy can lead to premature ovarian failure, especially in young females who are receiving chemotherapy or who are in the perimenopausal period. It can uh, lead to an early menopause in such patients. In females, unlike males, they have this complete hormonal or the menstrual cycle in which the follicles develop and then slowly mature and form the oocytes, which can then combine with the sperm and form an embryo. But unlike males, we cannot directly do a sample. They have to undergo the hormonal stimulation cycles or the LH and the FSH hormonal therapy cycles or estrogen and progesterone therapies to stimulate maturation of the follicles, division of the follicles into mature follicles, which can then be collected by needle puncture through the vagina and or through the abdomen by laparoscopic methods. The problem with this is the cycle usually takes 8 to 10 days for the hormonal stimulations and maturation of the follicles. This is possible in patients who are diagnosed with lymphoma, where we have time span which we can afford for collecting the sample or collecting the oocytes after hormonal stimulation. But in patients with hematological malignancies, this duration can sometimes be life-threatening, and patients can have complications like DIC, bleeding diastasis, low platelets, as well as the hormonal therapy increases the risk of thrombosis in such patients. So interventional procedures like oocyte retrieval in such cases is usually deferred or not encouraged in such cases. There is an option sometimes of the ovary preservation by laparoscopic resection, but there is a risk that this can carry the malignant cells along with it and can lead to transmission of the disease when the ovaries are replaced or the ovarian strips which can be collected and cryopreserved and then can be replaced after the chemotherapy. But this carries a disease risk of relapse at the isolated those sites if they are retrieved prior to starting the chemotherapy or the radiation therapy. With the advent of new drugs, it is still important that, especially in females, that they are phytotoxic and to some extent toxic to the ovary as well and to the endometrium of the uterus. So even if they can have the menstrual cycle, but the chances of continuation of pregnancy for the entire 9-month period and delivering a normal fetus is difficult in patients who have received chemotherapy because of effects on the ovary as well as effects on the endometrium and the uterus. So, how do we tackle such issues? Especially in females, we, if permissible, we try to do the oocyte travel and do an hormonal therapy and mature the follicles and do a transvaginal needle aspiration of the oocytes under ultrasound guidance, which is kind of a minimal invasive and if permissible with the platelet and coagulation corrections. But if not, and if the patient is having tumor lysis or having DIC manifestations or having a risk of thrombosis or bleeding or like brain bleeding with the hormonal therapies or dysfunction of the liver because of these hormonal therapies, which can be counterproductive, especially in patients who receive chemotherapy drugs which are metabolized by the liver. In such cases, we proceed with the chemo and try to do the hormonal or the oocyte retrieval or to do the ovary preservation post the induction chemo when the disease is under control. In males with CML, they can still be a father of their kid or their next child, but in females, I mean, especially in patients on imatinib, it can still be fetotoxic. So in such cases, or embryotoxic, so in such cases, the advised you have to first be in a total discussion with your hematologist or treating oncologist about whether you want to conceive. These drugs are kind of less toxic to the ovary, but they can be toxic. They are definitely toxic to the fetus and can be toxic to your endometrium or the uterus lining as well. So in such cases, there have been episodes that they can have early miscarriages or may not be able to continue the pregnancy for the entire 9-month period. In such cases, it is important that your first and foremost, your underlying disease, which is CML, should be under control. And if you have achieved the target of MMR, which is your RQ-PCR of BCR-ABL less than 0.1 or lesser, and you have achieved the target of treatment free, which we call as TFR with imatinib or with the newer therapies like nilotinib and dasatinib, you can go ahead with a consultation of your hematologist with a rigorous monitoring of monthly RQ-PCR, and if there is any change which can be detected by these sensitive methods, there is an option that you can be treated with interferon during your pregnancy period to keep the disease under control and avoid relapse or recurrence of the disease or progression of the disease while you're conceiving and trying to have your pregnancy. With the advance of new IVF techniques and with a proper consultation of your hemato-oncologist or BMT physician with the IVF specialist, males as well as females who have been diagnosed with cancer and have been treated with chemotherapies or intensive therapies like for acute leukemias or for transplant have some success in getting the next generation from themselves. I would be happy to answer or discuss this topic in much detail, but the take home message for this would be you should always and always discuss about your fertility issues before you go ahead with the chemotherapy if permissible, and take necessary steps for fertility preservations both in males as well as females, because in long run these have lot of psychological and psychosocial effects as well as financial effects on both yourself as well as on your spouse and your family in total. I would be happy to take any questions, or please write a comment about whatever questions you have regarding this topic. Thank you.